So what I generally hear people say when we go in and introduce ourselves and say we're part of the palliative care team is, but I'm not dying. And that's the big confusion, is that palliative gets mistaken for hospice, and we try our best to define what it truly is. And what palliative care really is symptom management and conversation and support for anybody that has a severe disease state. So it doesn't have to be cancer. It can be heart failure, it can be COPD, it can be any other myriad of chronic disease states that people can develop that have a symptom burden, and it doesn't have to just be physical symptoms. It is also, stress about, well, as I become more disabled, who's going to take care of my family? And we have social workers on our team that help talk through those things and get plans in place. And we help with advanced care planning. We help with, making decisions about what do you want to do the next time you come into the hospital, or what do you want to do right now? And so sometimes we do help transition patients to hospice, but hospice, it was originally created as an insurance benefit. So hospice is really a payment method. Palliative care is the type of care that hospice patients receive. It's just when you reach that time in your life where physicians are going to say, I think that there's a good chance they will no longer be with us in 6 months. That's when you're going to qualify for the hospice benefit. So we provide the same type of care. It's just when you qualify for hospice, you qualify basically for an insurance benefit in your last 6 months of life. The big thing for us that's not working is that we feel like that's just not known enough. So people that could benefit from palliative either don't understand what it is, or don't have access, or are afraid to let us in the room. And so we're not able to reach the amount of people that we would hope that we'd be able to with our current practices. Early palliative care can help with the burdens of chemotherapy and radiation for patients that are going through treatment for cancer. So we reached out to the different oncology offices that also practice at the hospital to just ask for 30 minutes of their time to say, hey, we're not here to take over, we're not here to take your patients away, but we want to help. We have the gift of time, so we can go in and spend an hour with these people that you may only have 15 to 20 minutes to go in, and we can really talk through a lot of what's going on with them and help them handle their treatment burden. And you may not have time to do that, so let us support you and your patients. And doing things like that have helped a lot, and then we expanded out to the hospitalist groups, and so we've just been slowly having one-on-one conversations instead of just throwing a banner out there that says, hey, we're palliative, everybody consult us. So I think the one-on-one conversations are helpful, and then that time we get to spend with patients to help educate them on what it actually is that we're trying to do also helps get the word out, because then they talk to their friends. And we've had people come in that have said, you took care of my neighbor and they were so happy with what you guys did when you were here. I asked for you when I got in the door. And so we've found that just interaction and face-to-face communication has been the biggest helper for us to get the word out. So I really wish people weren't so afraid of us, thinking that just because we're on the palliative team doesn't mean you have a death sentence. And so I wish people were not so afraid of the word palliative, thinking that we're only there to tell them that they're dying, and that's generally not the case. Generally it's that we learn you just hurt a lot, so we want to come help you feel better. The other thing would be to not have to jump through so many hoops to get people the medication that they need when they need it. I wish that the legal aspect, and then the insurance companies piggybacking on the legal aspect of trying to limit day supply or limit the total amount of morphine daily dose equivalents that someone can have wasn't there, because I spend so much time now just trying to fight with insurance companies to get people what they need when they leave the hospital, which then means we have a big chance that they're going to just have to come back in because they can't get what they need outside the hospital. So I wish that there was a way that we could not have such a severe pendulum swing into the direction of so many rules and hoops to have to jump through. It started with just having to put the diagnosis, and I'm just speaking to what I know of in Ohio. So in Ohio, we had to start with having to put the diagnosis code of malignancy-related pain, and then that did the trick, and it got people what they needed. Now it's to the point where we have to actually fax a note to prove that they have cancer in order to get them the medications that they need, and then hopefully the insurance company will turn around the prior authorization quickly, but they said they can guarantee that it's done within 48 hours, and so that just rubs me the wrong way. These people shouldn't have to wait 48 hours for adequate symptom control when they were very well controlled in the hospital, and all we're trying to do is transition them home. So I wish that something more could be done about that, and I'm hopeful that it will. I think we have to swing as far as we're gonna swing, and then it'll eventually start to come back. I just hope we stop somewhere in the middle this time. And just continued education, getting the word out there that palliative is a good thing, and that it can really help people have better quality of life and potentially, more life, because they're not suffering. And we all have read and know about the cases where, suffering can actually hasten the dying process. You're feeling not so good, and you bring in a team that can help you feel better and alleviate some of those worries, and people actually do live longer and have some more quality. So